Hello and welcome to our hip, spine and shoulder review video where I'll be talking about everything on the list and demonstrate some of the things. And for this one our camera is propped because our cameraman is gone, so let's jump into it.
We're starting with the greater trochanter.
So the greater trochanter, it is we have trochanter bursitis, trochanteric bursitis.
ACEs.
So ACEs, or anterior superior iliac spine, that is a hip pointer and where the sartorius originates.
Okay, psis.
And psis, or the posterior superior iliac spine, it is on the back or the top of the sacrum, and it is origin of the gluteus maximus.
Femoral necks.
Femoral necks, we have anatomical and surgical femoral necks. And anatomical ones is where the actual neck is, and the surgical ones is where the fracture occurs.
Okay, erector spinae.
Erector spinae, we have three muscles going medially to laterally. We have the iliacostalis, longissimus, spinalis, and then we have, so basically those muscles help us sit up straight. And then we have multifidus, which is the control center, control center of the spine.
Latissimus dorsi.
Latissimus dorsi, it's huge muscle on the back. It's going to originate at the T7 or the spinaeus process of T7 and go all the way down to the lumbar vertebrae, and it's going to insert at the medial intertubicular groove of our arm, and then it's going to be responsible for arm extension, abduction, and internal rotation or medial rotation.
Lower trapezius.
Lower trapezius is going to be responsible for shoulder depression.
Middle trapezius.
Middle trapezius is going to be responsible for shoulder retraction.
Upper trapezius.
And upper trapezius can be responsible for shoulder elevation. And we're going to have a CN11, which is an accessory nerve.
Great. C7 spinous process.
Yes, C7 spinaeus process. It is a bump on the back of our neck. We can palpate going down our cervical spine. It is the first large bump you'll feel, and that would be our C7 spinaeus process.
Okay, occiput.
Occiput, or as it's known, C0, it is above atlas, or basically just the back of our skull.
Okay, sternoclavicular joint.
We have sternoclavicular joint. It is going to be the only point where our body connects our upper extremity to our trunk. It's going to have cartilaginous, fibrocartilaginous discs in between the articulation points. It's gonna be a weak point. It's gonna have two types of dislocations. Dislocating most commonly anterior, where it dislocates anteriorly and superiorly, and in some cases very dangerous, it can dislocate backwards, posteriorly. Yes. This is where we're going to have some complications, and finally we're going to have a notch right here. It's going to be called the jugular notch.
Okay. Clavicular shaft.
The clavicular shaft, it is 6 inches long. It is the medial 2/3 of it. It's going to be convex and circular, and the lateral 1/3 is going to be concave, and it's going to be flattened. Basically, where that change from convex to concave happens is where most of our fractures are going to occur, or the medial 2/3, and finally we're going to have again dislocation backwards is life-threatening, and
What shape is it?
oh, sorry, it is an S shape. Yes, it's a little S. And finally, we're gonna have just one more point.
An athlete's.
Yes. So we know it's injured when the head of the athlete is tilted towards the injured clavicle, but the chin is facing away.
Yeah. Acromioclavicular joint.
Okay, for the acromioclavicular joint, it is the lateral farmost point of the clavicle and the acromion. That is where we have 6 types of sprains. The 4 through 6 ones are the surgical ones. We have 2 ways of injuring it. One way is falling on an outstretched arm or fooshing, and the other way is by falling on the tip of the shoulder. And finally we have the subacromial bursum. I went out of order.
Coracoid process.
For the coracoid process, we have short head, which is the biceps, and the long head, which is supraglenoid tuberosity.
Yes.
And for this one, we're gonna have axial nerve pain and pressure,
Mm-hmm.
right?
Okay. Acromion process.
Acromion process. It's just the highest point of our shoulder. Yep.
Humeral head.
For the humeral head, we're gonna have the medial tubercle, which is the lesser one, and the lateral tubercle. Oh wait, no, that's gonna come later. I think this just talks about dislocations.
Yes.
For dislocations, we're gonna have our. It's gonna most oftenly dislocate anteriorly and inferiorly.
Mm-hmm.
The deltoid will be flattened.
Mm-hmm.
There will be. Let me remember. There will be. So in some cases, the arm will be abducted and externally rotated and extended, and then.
What test?
Yes, apprehension test. We have anterior and a posterior apprehension test to test for anterior and posterior instability. And then we're going to have Bankart lesion, which is the one where we have the permanent anterior labrum tear.
Mm-hmm.
And we're going to have the Hill-Sachs lesion, where the head of the humerus, the head of the humerus goes back in place, but it's compressed. And finally, we're going to have the slap lesion, or the superior labral tear from anterior to posterior. And for slap lesion, we're going to have O'Brien's test.
Mm-hmm.
And after all that, we're going to have the scapulohumeral rhythm, which is so for first 0 to 30 degrees of the humeral rotation or abduction, we're going to have no rhythm, but after that, from 30 to 180 degrees of abduction, for every 1 degree of scapular rotation, there will be 2 degrees of humeral rotation.
Yes.
Yes.
Okay.
And then we're gonna have. I'm not done yet.
Yeah.
For fractures, we're gonna have a decapitating head of the humerus, and we're gonna have frozen shoulder, or it would just be adhesive capsulitis.
Nice. Good job.
Danko.
Bicipital groove.
Bicipital groove, we're gonna have the long head of the bicipital tendon. We're gonna have bicipital tendonitis there, and that is where the transverse ligament injury will occur.
Nice. Greater and lesser tubercle.
Yes, I was going to talk about those on humerus. So we have the greater tubercle, which is more laterally located, and we have the medial tubercle, which is, or the lesser tubercle, which is more medially located. Right.
Okay. Spine of scapula.
Spine of scapula, it's going to fracture from blunt force, and with there's going to be scapular dyskinesis, and the abbreviation for that is, or the acronym for that is SICK. So scapular malposition, inferior winging, coracoid soreness, and kinesis abnormality.
Nice.
Yeah.
Okay, next is scapular vertebral border.
Scapulovertebral border, that will be the border that's more medial, closer to our vertebrae. And then we have
Scapular lateral border.
a scapular lateral border, which is also sometimes called the axial border there's going to be more, well, as it says, lateral.
Scapular superior angle.
So we're going to have the scapular superior angle, which is the highest point of our scapula, and also we're going to have
The scapular inferior angle.
yes, which is the lowest point of the scapula.
Okay, SC ligament.
SC ligament, sternoclavicular ligament. We're gonna have we're gonna push down on the sternal end of the clavicle, and we're gonna push down on it, and it's gonna be anterior and posterior.
Okay, AC ligament.
For the AC ligament, it's gonna be anterior and posterior, and superior and inferior, and there's gonna be I'm thinking about the next one already. Help.
AC ligament. It's something about, I guess, indication of the shoulder blades. I don't know.
Yeah, just help me out here.
Shoulder pointer.
Right, right, the shoulder pointer, right. Okay.
Me not knowing how to.
Yeah, it's okay.
Okay.
There's not much you can. Yeah.
CC ligament.
So the coracoclavicular joint, ligament. Sorry, not joint. Ligament. That's the one that keeps the clavicle to acromion, and we're gonna have two ligaments there. One is gonna be the trapezoid, and the other one is gonna be conoid ligaments.
Okay, we're on the deltoid.
Yes, deltoid, we're going to have deltoid tuberosity, where it will actually insert. As for the origin, it's going to start on the lateral 1/3 of the clavicle. It's going to on the acromion, and also on the spine of the scapula. And the anterior, the anterior portion of the deltoid will be responsible for arm flexion, and also our medial rotation, and then we're gonna have the middle part, which is gonna be responsible for abduction, and we're gonna have the posterior part, which is gonna be responsible for shoulder extension. Yes, and also lateral rotation.
Yes. Good job. Subacromial bursa.
Subacromial bursa, it's the one that gets injured the most. It's gonna be up there with the tendon of the long bicipital tendon, long head. The tendon of the of the long biceps head. Oh, it's weird. And then it's gonna be up there with the supraspinatus tendon, and then that's where the shoulder impingement will happen.
Yeah. Okay. Pectoralis major.
Pectoralis major will originate on the it's going to start originating on the medial aspect of the clavicle. It's going to go down sternum and also the costal cartilage of the ribs, and it's going to insert at the greater tubercle of the humerus, and it's going to be responsible for arm flexion. It's going to be responsible for internal rotation, and it's going to be responsible for internal or medial rotation, and it's going to be responsible for the last one is which one did I not name? I named abduction. There you go.
Ab.
Yes, adduction. Sorry,
Adduction.
not ab. Adduction. Yes, and for pecs. Was it all for pecs?
That's it.
That is for
I'm
pecs.
just trying to figure out how to pronounce the next one. Sternocleidomastoid.
Yeah, sternocleidomastoid. There's things gonna sternum, clavicle, and mastoid. And in the mastoid process, we're gonna have Battle's sign, and it's gonna be it's gonna do all of the neck movements except for neck extension, and it's gonna be where the carotid artery is gonna be.
Okay. A biceps brachii muscle and tendons.
Can you say that? Oh yeah, the biceps muscle and tendons. So we're gonna have the C5 reflex. We're gonna have two heads. The long head is gonna originate on the supraglenoid tuberosity, and
Yeah.
and the short head is gonna originate on the coracoid process,
Yeah.
and they're both gonna insert at the, let's see here, radial notch of ulna.
Yeah.
There you go.
There's another point for long head.
Oh, and for long head, that is actually where the the bursa is gonna be, right? Nope,
has
that
something
was
to do
not
with-
it.
No.
Not subacromial bursa?
It's not about the area. It's just about
No, is
like
it?
an injury. I guess I don't know.
Oh, what is it? Just tell me.
Where the shoulder impinges.
Yes. The subacromial bursa, shoulder impingement. Yeah.
Okay.
It all goes. Yeah, there was supraspinatus.
Rhomboids.
Rhomboids. We have minor and major. Major is gonna be below, or minor is gonna originate. Oh, they're both responsible for shoulder retraction and stabilization. Minor is gonna originate on C7 and go to T1, and then major is gonna be T2 to T5,
Yes.
and I believe that is all for the rhomboids.
What is the insertion?
Oh, right. The insertion point would be at the the vertebral border of the scapula.
Good job.
Yes.
Triceps brachii.
Triceps brachii. That is our. We're gonna have three heads. We're gonna have the medial, lateral, and the long head. And so the medial and lateral are both gonna originate on the back aspect of the humerus, and then the long head is gonna originate on the glenoid tuberosity, and let's move on.
Tuberosity of.
Oh, of the scapula, yes.
It also says.
Yes,
something about
they're gonna be in the back, yeah.
which ones?
The medial and the long. No, the medial. Sorry, and the medial and the.
No, not medial.
The long and
Yeah.
the long and the lateral.
Yeah.
The two L's are gonna be in the back.
Yeah. Medial and lateral is on the posterior surface, but it says long and lateral is from the back.
Yes, it's confusing with the insertion points.
Okay. Serratus anterior.
Serratus anterior is gonna innervate the first 9 ribs. It's gonna insert, which is the hard part, at the medial, costal, medial margin.
Keep the two M's together.
Yeah, keep the two M's together. Medial margin of medial margin of the scapula.
Yeah, sure, yeah.
Close, very basically.
It's basically.
And they're gonna be responsible for protraction.
Yeah.
They're basically gonna look like fins. That's what the winged scapula is, and finally there's one more.
Cute more.
They're gonna.
Oh.
Well,
Not two more.
yeah.
Can you name a nerve?
Oh yeah, the long thoracic nerve. That is very my bad.
And is there a feature to the scapula?
Oh, I said wing scapulas.
You did? Okay.
Yeah, come on. Give me.
Supraspinatus?
The supraspinatus is gonna be. It's gonna insert at the or originate at the supraspinatus fossa. It's gonna insert at the greater tubercle of the humerus. It's gonna be responsible for shoulder abduction, but it's not a very strong shoulder abductor. It can only do about 5 pounds of abduction, and it's also gonna do internal rotation.
No.
External. Is it? No, wait. It's medial, internal.
Lateral.
Lateral. Okay. Yeah, lateral rotation. Yes.
And shoulder impingement.
Yep. Shoulder impingement.
I don't know how to explain.
Yes. Yeah.
Okay.
All that area with supraspinatus and the bursa.
Okay. Infraspinatus.
Infraspinatus is gonna originate in the infraspinatus fossa. It's gonna again insert at the greater tubercle of the humerus. It's gonna be responsible for again, this one's going to be responsible for adduction, and it's also going to be responsible for lateral rotation.
Yes.
I believe that's all.
Insertion.
Didn't I say at the greater head of the tubercle?
So awesome. Forgot.
Yeah.
Teres, major and minor.
So teres major and minor. Teres minor is part of the rotator cuff. Major is not. Major is also below, and major is responsible for adduction, whereas minor is responsible for external rotation.
Okay. Sciatic nerve.
Sciatic nerve. There's sciatica, or the inflammation of the nerve.
Okay. Lumbar plexus.
Okay, lumbar plexus. It's gonna be L1 through L4, and here go the nerves. There's gonna be obstructor, close enough. Obstructor.
Yeah, sure.
Okay, obstructor nerve. We're gonna have the femoral nerve, the tibial nerve, the medial and lateral plantar nerves. We're gonna have the soleus nerve. Close enough. Soleus.
Yeah. Sure.
Hey, come on, give me a soleus. So.
It starts like sure.
Okay. Soleus.
Sural.
Sural. So, I'm thinking soleus. Sural nerve. Sural nerve, and then we're gonna have three peroneal nerves. We're gonna have the superficial and the deep peroneal nerves, and we're gonna have the common peroneal nerve.
Okay. Brachial plexus.
Was that all for the? Yeah.
Yeah.
Okay, for the brachial plexus, we're gonna have. It's gonna be C5 through T1.
Mm-hmm.
Good. And then we're gonna have the axillary nerve. We're gonna have the muscular cutaneomuscular nerve. We're gonna have the ulnar radial medial nerve. And then we're gonna have stingers and burners, and that would be the brachial plexus neuropraxia. And then we're gonna have thoracic outlet syndrome, TOS, which is we're gonna have the compression of the plexus and the long thoracic nerve.
Yeah. Femoral artery.
And femoral artery, it's gonna have the inguinal triangle, which is comprised of the inguinal ligaments, or femoral triangle, sorry, not inguinal triangle, femoral triangle, which is comprised of inguinal ligaments, sartorius, and adductor longus.
Brachial artery.
And the brachial artery, that is the emergency point for infants. It'll be right here.
Nice.
Okay, butchered
Good
a
job.
few. Butchered the names. What was the obstructor? Was it obstructor? Obstructor.
It sounds so aggressive. It's obturator.
Obturator. Obstructor. Obturator. And then
Sural.
sural nerve. Obturator and sural.
You're like solar.
Thank you for watching.